All right, today we are tackling a big one, diabetic ketoacidosis, or DKA. This is a true medical emergency, and we're going to break down everything you need to know, from the absolute metabolic chaos happening inside the body to the step-by-step plan that restores control and saves a life. So, just imagine for a second, what happens when the body's entire system for managing energy just completely breaks down? That, in a nutshell, is DKA. It's this rapid, terrifying spiral where the body essentially turns on itself. So let's get into the why behind this crisis. To really get a handle on treating DKA, you first have to understand how this perfect metabolic storm even happens in the first place. And it all kicks off with one missing, absolutely critical hormone. At its heart, DKA is really a triad of three huge problems happening all at once. First, you've got hyperglycemia. That's sky-high blood sugar. Second, ketosis. The body is churning out these acidic compounds called ketones like there's no tomorrow. And third, that leads to metabolic acidosis, where those ketones make the blood dangerously acidic. You need all three of these to make the diagnosis. So how does this whole terrible cycle get started? Well, it begins with a severe lack of insulin. Now think of insulin as the key that unlocks your cells to let glucose in for energy. Without that key, the glucose is stuck outside, just piling up in the blood, and boom, that's hyperglycemia. Meanwhile, your cells are literally starving, so the body panics. It starts burning fat for fuel instead. This process, called ketogenesis, has a nasty byproduct, ketones. And these aren't just any byproduct. They're acids. They build up so fast that the body just can't handle them, leading to metabolic acidosis. And finally, to top it all off, the kidneys try to get rid of all that extra sugar and ketones, but in doing so, they drag huge amounts of water and electrolytes out with them. This is called osmotic diuresis, and it leads to profound dehydration. It is a truly vicious downward spiral. Now, what kicks all of this off? DKA almost never just happens out of the blue. It's usually triggered by some kind of major stress on the body. The most common triggers? Things like infections, pneumonia or UTI are big ones, or a patient simply not taking their insulin. But it can also be the very first way someone finds out they have diabetes, or it can be set off by huge events like a heart attack or stroke. Okay, so now we get why it happens. Let's switch gears and talk about how to spot it. What does a patient in DKA actually look like, and what are the hard and fast criteria we use to lock in the diagnosis? The symptoms come on fast. We're talking hours to maybe a couple of days. You'll see the classic signs of high blood sugar, right? The excessive thirst, the constant urination. But DKA brings this whole other layer of really intense GI distress. We're talking nausea, vomiting, and this generalized belly pain that can be so bad it can actually look like a surgical emergency. As the dehydration gets worse, their heart starts racing, and then you get two of the most classic telltale signs: a fruity, almost nail polish remover smell on their breath. That's acetone, and a very, very specific way of breathing. And that breathing pattern has a name: Kussmaul breathing. Now, this isn't just breathing fast. These are deep, labored, almost air-hungry gasps. This is the body's last-ditch, desperate effort to fix the acid problem by blowing off as much carbon dioxide as it possibly can. When you see this kind of breathing, your brain should immediately scream metabolic acidosis. So to officially make the call, we don't just guess. We look at the labs. And according to the American Diabetes Association, you need these three things: a blood sugar of 200 or more. You need significant ketones, ideally a beta-hydroxybutyrate level of 3 or higher. And you need proof of acidosis, which means a bicarb level under 18 or a venous pH less than 7.3. It's a three-part diagnosis. Now, one really important thing to distinguish DKA from is its cousin, hyperosmolar hyperglycemic state, or HHS. They're both emergencies from high blood sugar, but they are fundamentally different problems. With DKA, the main villain is the acidosis from all those ketones. With HHS, the main problem is just an insanely high blood sugar. We're talking way over 600, and the extreme dehydration that comes with it. In HHS, you just don't see that massive ketone production, so there's no real acidosis. So, to sort all this out, you need a specific set of labs, and you need them stat. You've got to get a glucose and ketones to confirm it, a VBG to check the pH, and a full electrolyte panel. And you need to pay very close attention to that potassium level. We'll see why in just a minute. You also check kidney function and a CBC to hunt for an infection. And an ECG is also critical because it can give you clues about what that potassium is doing to the heart. Okay, the diagnosis is in, now we have to move, and we have to move fast. Managing DKA is a step-by-step process with three main pillars. And believe me, The order you do them in is everything. It's absolutely critical for the patient's safety. Here they are, the three pillars: fluids, potassium, insulin. And they have to be addressed in that exact order. You have to tackle the dehydration and check the potassium before you even think about starting that insulin drip. This is a non-negotiable safety step, and we're about to see why. Priority number one, always, 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 is aggressive IV fluids. These patients are incredibly dehydrated, sometimes down by several liters of fluid. Our first job is just to fill up the tank, restore their blood pressure, and get blood flowing to their organs again. We usually start with isotonic saline and run it in fast, like 500 to 1,000 milliliters an hour for the first few hours. Okay, pop quiz. This is a life-saving question. You've got the IV fluids going, the patient's starting to look a little better, and you're ready to hang the insulin to fix the root cause. But there is one specific situation where starting insulin right away would be a catastrophic error. What is it? You absolutely 100% must hold the insulin if the patient's serum potassium is less than 3.5. Here's why this is so important. Even though their initial potassium level in the blood might look normal or even a little high, their total body stores of potassium are actually incredibly low because they've peed it all out. And one of insulin's other jobs is to shove potassium from the blood into the cells. So if you give insulin when the blood level is already low, you'll cause a catastrophic drop, leading to severe hypokalemia, which can trigger a fatal cardiac arrhythmia. This table is your playbook. If potassium is low, less than 3.5, you give potassium first and you wait on the insulin. If it's in that normal range, you start adding potassium to their IV fluids right away because you know it's going to drop once the insulin starts. And if it's high to begin with, you can hold off on giving potassium for now, but you have to recheck it in a couple of hours because it will come down. Once the potassium is safe, we can start the IV insulin. Now, the main goal of the insulin here isn't just to lower the blood sugar. It's to shut down that ketone factory. That's what's going to fix the acidosis. So we start a continuous drip. And then, as the blood sugar starts to fall, we make a really important change. Once the glucose gets down below around 250, we actually add sugar, dextrose, to their IV fluids. Now, I know that sounds crazy, but it's brilliant. It lets us keep the insulin running to clear out the ketones without crashing their blood sugar into a hypoglycemic range. Remember, we stop the insulin when the acidosis is fixed, not just when the sugar is normal. Managing DKA is not a set it and forget it kind of deal. This is incredibly active management. We're checking their blood sugar every hour. We are rechecking potassium and their other electrolytes constantly, especially in those first few hours, so we can adjust on the fly. You're constantly reassessing and tweaking your plan based on what the labs are telling you. All right, the patient's finally turning the corner. The crisis is stabilizing. The final phase is all about getting them safely off all these IV drips and, just as important, making sure they know how to prevent this from ever happening again. So how do we know when we've actually won? When is the DKA resolved? Well, we have a clear checklist. The blood sugar is under control. The acidosis is gone, which means their bicarb is up above 18 and their pH is over 7.3. And crucially, the patient is awake, they're with it, and they're able to eat a meal. Switching from the IV insulin drip back to shots is another moment where things can go wrong if you're not careful. IV insulin is incredibly short-acting. It's gone from the body in just a few minutes. So if you just turn off the drip, they're suddenly without any insulin and they can bounce right back into DKA. The key is to create a bridge. You give their first shot of long-acting, subcutaneous insulin, and then you keep the IV drip running for another hour or two. That overlap gives the long-acting shot time to kick in before the IV insulin wears off. And finally, the most important part, preventing the next episode. This all comes down to good patient education, specifically what we call sick day rules. The number one rule they must know is to never stop taking their insulin, even if they're sick and can't eat. In fact, when the body is stressed from an illness, it often needs more insulin, not less. They need to know how to check their blood sugar and ketones at home, how to stay hydrated, and when to call their doctor before it becomes a full-blown emergency. And that really brings us to the final, most important point. Getting a patient through a DKA crisis is a huge clinical win, for sure, but the real victory is making sure they never end up in that crisis again. It's a powerful reminder that our job doesn't just end with a normal lab value. It extends to education, support, and truly empowering our patients.